All right, well, welcome everyone to the Research Ethics and Policy series. Hello to those of you who are joining us online. My name is Holly Fernandez Lynch. I am the co-chair for this series along with Steve Jaffe, who is on vacation, so he's not here today. I'll just say a couple of kind of housekeeping announcements before I introduce today's speaker. But I will whet your appetite for next month when we'll be joined by Professor Dorothy Roberts from the law school. And she's going to be talking about the recent National Academy's report on using population descriptors in genetics and genomics research. And you can find our full list of speakers coming up on the departmental website. If you have ideas of people that you'd like to hear in this series, especially people who can contribute diverse perspectives, please reach out to me, Steve, or Lisa to let us know who we should be thinking about inviting. We have a couple of free online resources that our department offers that are relevant to research ethics and policy, some of which can be used for free continuing education credit and also in satisfaction of the research ethics training requirements at both Penn and CHOP. And this is a new one, so pay attention if you don't normally pay attention to these slides. We just wanted to also let you know that there is an online graduate course, a credit-bearing course that is offered through our Master of Healthcare Innovation in our department, focused on value and quality, taught by Lee Fleischer and Neha Patel. Dr. Fleischer was previously a leader at the Center for Medicare and Medicaid Services, in addition to being a faculty member here at the School of Medicine. And so you are welcome and encouraged to take a look at that class. Okay. And with that, just a brief note of thanks to our sponsors for the series. A special thanks to Lisa Bailey for making sure that things go off without a hitch. And then I will introduce you to today's speakers, who are going to be talking about the evolution of quality improvement in research ethics. Dr. Jennifer Myers is professor of clinical medicine here at Penn, where she directs the CHIPS Center for Healthcare Improvement and Patient Safety. Dr. Myers has devoted her career to improving the quality and safety of healthcare and training the next generation of physicians and other healthcare providers in quality. Of course, relevant to today's talk, she's also conducted a wide variety of quality improvement research herself, so has expertise in how it's overseen and some of the research ethics challenges that come up in that context. And then we have a 2-for-1 today. We're also joined by Dr. Shivan Mehta, who is Associate Professor of Medicine with appointments at HUP and at the VA Medical Center. He's a clinical gastroenterologist and co-director of quality for the Division of Gastroenterology. He's also Associate Chief Innovation Officer for Penn Medicine and Director of the Center for Healthcare Transformation and Innovation's Population Health Lab. He has led and evaluated 20, probably 20 plus now at this point, pragmatic trials of healthcare delivery that leverage behavioral science, care redesign, and information technology to improve population health outcomes. So typical kind of rules apply. We will toggle between those of you who are online and those in the room to ask questions. We hear this is intended as a conversational talk today. So if you have questions as our speakers proceed, please feel free to raise your hand and we don't have to wait until the end for those questions. We are recording this session, and so that will be posted on our department's website as soon as the recording is processed. All right. With that, I will turn things over to you. Take it away.
All right. Thank you, Holly, and good afternoon, everyone. It's nice to see you. Thank you so much for the kind introduction. This is a favorite topic for Dr. Mehta and I to talk about. And we actually thought we'd start by telling you a little bit about our backgrounds and a story. So about 10 to 12 years ago, I was leading a lot of quality improvement work and developing several training programs for residents and junior faculty in healthcare quality. And at the health system level, we have a blueprint for healthcare quality at Penn Medicine to kind of guide our efforts. And one of those blueprints, the iteration 2.0 in 2014, really identified the need to have more providers be engaged. And so at that time, we started several training initiatives, one of which is still in place today, and it's called the Healthcare Leadership and Quality Track. And so you can imagine you have residents, whether they're surgery residents or medicine residents or anesthesia, they're learning about quality. They want to improve the care delivery for their healthcare population, but they also, want to get their next job, want to match into fellowship, and are being expected to do some scholarly work. And therefore, they want to publish the work that they're doing. And they were running into barriers and lots of questions. Let me illustrate this with a story. This was a project that I was a mentor on related to medication reconciliation. If you're not familiar, this is the process where we make sure that the patient's previous home medications were compared against the hospital medicines at discharge to make sure we're not making any errors. Trust me, it's a process fraught with the potential for error. So we had two medicine residents. They worked with pharmacists at the hospital, the University of Pennsylvania, to design a project where the pharmacists could actually go in, find the errors or problems, make the changes, and call them to let them know, rather than doing a lot of phone tag. And so it was successful. It was popular among the staff, and they wanted to present their work at a national meeting, and they actually wanted to write up their work. And so they did this. Again, this was back in 2012, 2013. At that time, we didn't have a QI IRB pathway. That did not exist. This was right around the time I met Shivan, and we'll get to that story in a minute. And so it went to the IRB. It was put into the expedited review pathway, and took actually about 2 to 3 months to get approval. But this caused a lot of consternation because we wanted to get the project started in a timely fashion, and they're not here for a very long time. And so while I was working through this with them, we were getting lots of other trainees that were getting mixed messages from their faculty about, does this quality improvement project need to get a full IRB approval or not? Because their mentors had never done this work before. They had only mentored research studies, whether they were basic science studies or clinical research studies. So this was all really a new field. And so I'm going to hand it over to Shivan, but I just want to say how we met. So I teach a graduate course in quality improvement and patient safety, and it must have been like early, the second or third year that I did it. Shivan was getting his master's and took my class because he's interested in healthcare delivery improvement, and he's going to tell you about his project.
And both Jen and I have our own sort of war stories of how to kind of navigate the system and navigate this new type of research. And so I was a third-year fellow in gastroenterology. I was also a master's of science and health policy research, and I was taking Jen's course on quality and safety. And as part of the course is that you have to learn by doing. So you have to actually do a project that you can actually run over the course of that semester, which is actually pretty challenging to do, but at least you have to kind of get things started. In addition to that, our fellowship had to, some of the requirements from ACGME at the time was that each fellow or fellowship group had to do a quality improvement project. So the hope was to align my project for this class with the things that my co-fellows have to do at the same time. And so one big issue for us, as we, a lot of what we do in gastroenterology is screening colonoscopies. March is Colorectal Cancer Awareness Month. Hopefully this isn't too graphic for a lunchtime talk, but many people that come in because they get open access endoscopies, particularly at Penn, where we have a very diverse patient population, and they may not see a gastroenterologist first, they have to drink the prep and go through that whole process. And so at the time, about 30% of afternoon preps were fair or poor. In the spirit of quality improvement, we looked across the literature, we looked across what other people have done, and we found actually randomized controlled trials and lots of evidence showing that if you switch to a split dose prep, meaning you drink half of it the night before and half of it about 4 to 6 hours before, you get a much higher prep quality. However, also in the spirit of quality improvement, there's a lot of resistance and anxiety about switching to that because, maybe it might be hard for the patients to understand. Maybe they might drink too late, so the case might get canceled by anesthesia. And so we wanted to run it as a quality improvement program where we actually implemented it and understand that. And my mentor at the time, Dave Metz, who was the associate chief for clinical affairs in our division, said, "Oh, if you're going to do this, like we're academic, we should, you should send it to the IRB just in case we want to present it at a conference or write a paper about it." And so I submitted to the IRB, being a diligent fellow, and it took many, many months to come back. So first of all, I think they were trying to, and only now do I realize what some of the challenges were. They're trying to grapple with, is this a research project? Is this an operational project? And when they came back, they actually said that we had to get informed consent from all of our patients before we offer them this intervention, which in routine practice, if we didn't send it there, we never would have done that because we're making changes all the time in, phone calls that come in, changing our instructions or things like that. And so I think that crystallized in my mind kind of a problem there. And as I became involved with the Innovation Center, we were trying to think about what are big platforms or what are big impediments that prevent lots of people from doing lots of innovation, quality improvement projects and research projects across the health system. And this case is sort of still in my mind and crystallized there. So I'll hand it back to Jen.
All right. So what we'd like to do is talk a little bit about what is the current state of quality improvement work in healthcare and in particular in academic health centers. We're then going to talk about the Penn's QI-IRB pathway, which Shivan and I helped to create in partnership with Penn's IRB, talk through some case studies, and then hopefully have a rich discussion with all of you about the ethics behind all of this and see what questions you have. Okay, so the word quality and safety in healthcare literally was not a thing until 1999 and 2001, when these two reports were commissioned by the National Academies of Medicine. The first was called "To Err is Human," just a call to action that preventable medical errors happen. And instead of accepting it as part of the business, we really need to investigate it and correct systems problems that lead to them. And then 2 years after, Crossing the Quality Chasm was published, and that said, okay, how do we think about improvement in the healthcare system? And it gave us a framework to think about it. So it's not just care that's safe, it's also care that's effective, efficient, timely, patient-centered, and equitable. These are considered the classic domains of high-quality healthcare. And as a quality improvement practitioner and educator, I see projects in all of these spheres, and so does Shivan. So along with these white papers from the National Academies, there was a lot happening in healthcare in the early 2000s, some of which are still going on today, that were really driving hospitals, hospital administrators, physician leaders, nursing leaders to pay attention to quality where they had never paid attention before. So just a few are listed here. So hospital accreditation requirements, if you've ever heard of the Joint Commission, it's been around for a long time as a nonprofit watchdog for hospitals, but they started to get much more specific about patient safety goals and quality expectations. And they survey us, and we can get black marks or red marks, if you will, if we're not up to snuff, which does not look good on our hospital. Safety events can lead to medical malpractice. That obviously is something that gets the institution's attention and sometimes gets media attention. The government, the Center for Medicare and Medicaid Services, began to experiment with pay-for-performance programs. So initially, they just were paying us to show us the data, like, please let us look at it. And then they started getting specific around things like, are you using an evidence-based medication for all of your discharges in patients with heart failure, let's say, or pneumonia? And that was all very new. Many of the insurance companies similarly got on this same bandwagon to say, well, we only want to pay for care that's high quality and high value too. And so they started to work that into some of their contract negotiations with Penn and other health systems. And then there's a lot of publicly reported data, whether or not patients look at this or not, that's a whole nother talk in and of itself. But just to know that it's out there, groups like Leapfrog, the nursing quality indicators, many specialty service lines have centers of excellence, and they're looking at specific outcomes. And you can find how we do on the web. And then Shivan alluded to this, this whole shift in thinking about quality and safety makes you think about, okay, when do doctors in training or nurses in training or pharmacists in training, when do they learn about this? Well, it was never in my curriculum. I trained in the 90s. And so the ACGME, which credits all of the graduate medical education programs in the country, so residencies and fellowships, they changed their common program requirements to include quality improvement, to improve patient safety. And to Shivan's earlier point, they expect to see education and some involvement in quality efforts. So there were more program directors reaching out to people like me to say, well, how can I help my trainees do this work in a good way? And I mentioned nursing and pharmacy as well. And then just sort of, and this relates back to the pay for performance programs, whenever money is involved, people are paying attention. So the health system, finances were also impacted by some of these pay for performance efforts. Okay, I think what I wanted to leave you with is that there are hundreds, if not thousands, of QI efforts going on at any given time across Penn Medicine. And I made this table just to sort of give you a bird's eye view. Some of them are very macro. So at the health system level, right now, actually based on a Blue Cross value and equity-based performance initiative, all the hospitals, all 6 to 8 of them, are working on reducing inequities in heart failure readmissions. So they're looking at their data, how many of them are in Black population, how many of them are in white population, other ethnicities. Is there a disparity? If so, how big is that disparity? What could the reasons be? How could we close that gap? So that's quality improvement that's happening at a very high level. There's people devoted to this team and chief medical and chief nursing officers that sponsor the work. Then at the meso system, whether it's like the Division of Gastroenterology or, the cardiovascular service line or the Department of Medicine, there are systems that they're focused on a specific thing. So we could even say improving colonoscopies, perhaps in some ways, is a meso quality improvement goal. I put this one here just because it's close to my heart. So primary care service line works closely with GI to try to improve colorectal cancer screening rates. And so that has been going on for many years, continues to go on as a collaboration. And then there's things that happen at the micro level, really small, kind of a group of people just wants to roll up their sleeves and get it done. So let's say a medical unit is working to increase naloxone prescriptions on discharge for patients with opiate use disorder. They recognize it as a gap. They make some changes in working with the nurses, pharmacists, and providers. So all sorts of levels of this work happening. And the key point here, there's so many. They're designed to improve the healthcare delivery system and the outcomes of patients and patient populations. That's what we're all here for as healthcare providers and clinicians. And the changes are within the usual scope of practice, right? It's not something out of scope, but improving that process does take time, thought, and coordination. And what we want you to come away with from this talk is the vast majority of this work does never need to go to the IRB, nor do they want to see it. And the only reason that we're invited here today is because this is Penn, right? The University of Pennsylvania. So many people that are clinicians and even non-clinicians here, right? They have another goal. And that goal is to publish their work, to contribute to generalizable knowledge. And so there's this rub. I like this slide because it really shows the spectrum across of clinical practice versus QI versus research. We're always adapting and innovating at the individual patient level. Then over here on the right, I think we are all familiar, this audience is familiar with a clinical trial, a basic science study, where your goal is to develop new knowledge to help the field, to help patients and patient populations. And I would assert that quality improvement is in the middle, right? We're learning, but we're learning in a systematic, experiential way. And we can't have this like rigid protocol and never deviate, because we're going to learn things along the way that we want to spread quickly to all of the patients. And so it generally is an iterative process. We call them plan, do, study, act cycles. So the lines can get blurred. And again, we shared some of that blurriness with our stories early in the talk. And this is why our QI-IRB guidelines were developed. I just want to share a little bit. I get asked to talk a lot about quality and safety in academics. And I just, if we rewind the clock, even 10 years, 15 years, these are the career paths. Some people are basic scientists, some people are clinical investigators, some are clinician educators, but the metrics of success have kind of always stayed the same: publications, grants, teaching evaluations. With the advent of quality and physicians and other healthcare providers wanting to actually do this work as part of their job, we now have clinical quality improvers. I'm one. And doing high quality healthcare improvement work is a metric of success. So there are hundreds of faculty at Penn Medicine that get promoted, and their area of concentration is healthcare improvement. And so it's one of the exciting things that I've been able to observe and help foster here at Penn Medicine in my career. Just to prove this to you, this is just taken from our Penn website. This academic clinician track is one of the 4 faculty tracks. You can see a little just call out there. The major emphasis of this track are clinical care, quality and safety, education, including leadership in these domains. So it's well recognized and accepted. And then I just put this, this was a paper that looked at several departments of medicine across the US, where they were noticing that many people had guidelines to help their faculty that did this work get promoted and have it count. What about quality improvement scholarship? So have any of you in the audience heard of Squire? Just one person has? Okay, but mostly no. Okay, and I'm not surprised if it's a non-QI audience. So Squire stands for the Standards for Quality Improvement Reporting Excellence. And a group of leaders out of Dartmouth came together to create these guidelines, because prior to these guidelines, healthcare delivery improvement work, quality improvement work was being submitted to journals, but in a really haphazard, somewhat sloppy fashion. Yet we wanted to move the field forward. And so they came together to say, okay, here is how we would like you to write about your work in a scholarly way. And so the first version of the guidelines was published in 2010. A second version was in 2016. I'm actually part of the version 3.0 that's currently being developed that has a special emphasis on equity, which I'm excited about. And, now if you look at all of the other guidelines, maybe that you might be more familiar with, Consort for RCTs, PRISM for systematic reviews, we have Squire for quality improvement reports. So this has been really helpful as a journal editor or somebody that reviews journals to fall back on. And also for people like Shivan and I to give mentorship to others about, let them know that they exist, use it as a guide with their publications. The growth of publication opportunities in this space has been enormous. So not only are there many more specific journals just focused on the broad field, you can see them there on the left. I tell my residents and co-faculty, just look at your clinical journal, like the most clinically focused journal, and I guarantee you there's some column there that will accept work for well-done innovation studies, because we're all trying to learn, we're all trying to solve the same problems. It's not just Penn that has trouble with colonoscopy preps or getting naloxone to patients on discharge. They often call them different things, so you have to be savvy and read the fine print, but the number of publication opportunities has really increased. And I'm going to hand it off to Shivan to talk a little bit about our QI-IRB pathway.
Yeah, so once Jen and I kind of got together to start talking about what we can do to figure this out, provide guidance to our trainees, our faculty across the institution, we obviously needed to work with the IRB. And the first thing I'll say is that our IRB is fantastic to collaborate with. They're very forward-thinking, even as I talk to other institutions. So we actually worked with Tracy Zielik and Megan Katzmatis, who neither of them are here anymore, but there's still folks from the IRB that we still work with. And it was really great to kind of get that perspective from their level to understand sort of like, what do they worry about? From our perspective, it was easy. Do we need to go to the IRB or not? How can we think about more streamlined pathways so it doesn't slow down the quality improvement or innovation work that we're engaging in? How do we provide guidance to all the different mentors out there that may not have this type of training? How do we facilitate this more? How do we think about what we might call a more traditional research project versus a quality improvement project? And from the IRB, we learned very quickly that they don't feel comfortable at all in answering some of these questions because they don't have that operational lens. They don't know if it's an initiative that's sanctioned by the health system or if it's an initiative sanctioned by the Department of Surgery. So for them, they wanted to know what's the primary goal of your work. And they also, to Jen's point, didn't feel like they needed to or had the capacity to review every quality improvement project out there. And so they wanted to find mechanisms to understand what the intent was, a way to engage with operational leaders to understand if this was truly sanctioned or if this was just a student coming up with some idea that had not been sanctioned yet. And then finally, how can you identify the small subset of projects that should go through the traditional IRB? And so in the spirit of that, that's how we came up with this concept of kind of calling it sort of like a QI IRB. When it's not really a QI IRB, it's just a QI evaluation pathway. Some of them will go to the IRB and a lot of them will not go to the IRB. And so in the spirit of quality improvement, we wanted to think about this as a pilot and think about it in a systematic way. And so as we think about quality improvement in research, it's very easy to think of these as sort of separate things. And you saw that continuum. But what we've learned is that there's actually a lot of overlap here. And frankly, Penn Medicine and Penn as an institution, we're leaders in this space in terms of bringing together operational leaders and researchers to solve problems that both locally and to create generalizable knowledge. And many of us, Jen and myself, both actually wear both hats in some context. So I co-lead quality for gastroenterology. I'm sort of one of the clinical leads in thinking about colorectal cancer screening rates. I also have an externally funded portfolio thinking about research in this space too. And so trying to figure out that dynamic. And so when we think about sort of the distinction and the overlap, quality improvement typically, as Jen described, is more about local improvement in process or outcome. And that's typically where the primary goal is. While traditional research, the primary goal is generalizable knowledge. Sometimes, I think that this is where we're sort of getting into that sort of nuance and that gray area. Sometimes there may be a secondary goal to kind of create generalizable knowledge in quality improvement projects. And many of us have that lens in mind. And in research, there might be a secondary goal to improve local process and outcomes, because now we're finding more research is sort of co-funded or co-supported by both external agencies and our health system or our institution. Typically, the scope of quality improvement leans more towards existing standards of care, while things that are testing new methods and models might lean more towards traditional research, but there's certainly a continuum there. Our hope when we work with trainees is that evaluation should be as rigorous as possible for both quality improvement and traditional research. We should be hypothesis-driven with systematic data collection. So I think that the key thing to highlight also is that quality improvement doesn't mean worse evaluation or just sort of sloppy methods or not thinking things through. We want people to be thinking as clearly about quality improvement. And that's why, the Squire guidelines are useful in terms of thinking about having a systematic approach to describe quality improvement, which might be messy. Things change. It starts off as one project, it ends up pivoting to something else. It's multifactorial, so you may not know which of the 10 different things that you did might have made a difference or not, which is a little bit different than research. Typically, traditional research has to get IRB approval, while quality improvement historically has not, and they both have to follow HIPAA pathways or HIPAA guidelines. And the key here is that overlap. And now you hear a lot more about either learning health system. There's a big PCORI grant that our institution received to support. It's a P30 grant to support learning health system to fund both operational leaders and researchers to kind of come together. So we're explicitly doing that. Healthcare delivery science is another way to describe it. Implementation science is another way to describe it, sort of from different frameworks and different lenses. And so I think trying to kind of think about that overlap is what we've tried to kind of model. And so, as I said, as we worked with the IRB, and this was probably 8 or 9, this was 2014, so about almost a decade ago, we said, let's actually create a pilot. Let's try to bring in as many ideas and many submissions as possible, because at that time we only knew what we had experience with, our own lens. And so we put this out as a pilot. We socialized this to lots of different venues, both research venues and operational venues, sending it to the CMOs and department chairs and things like that. And we said, if you have something that you think is within this realm, just submit as much as you can, because we want to learn as much as possible. And actually, if you submit it, we'll actually give you some guidance about what we think you should do. And so we ran it. We had about 100 projects that were assessed. And this was all assessed by the folks from the IRB, sort of working with us to kind of think through some of the edge cases. 2/3 of them did not require full IRB. 90% of individuals that submitted, we also got feedback from submitters, were satisfied with the process. 90% would resubmit. And I think this is probably perhaps the most important part for me, is that most QI pathway approvals are returned within days. You get a response back a couple of days later, and they're actually quite easy to fill out. It's only a 2-page application. You have to sort of describe it very, very quickly. You put it in, you submit it, and that's where we really appreciate the guidance from the IRB group, because in the idea of making it as user-friendly as possible, we want people to submit it. We don't want to create extra barriers. And so some interesting examples that we found that I think highlight sort of this concept of intent and operational leadership is that these are 2 different projects. One is at HUP, one is at Pennsylvania Hospital. Both of them were retrospectively reviewing inpatient hospitalizations for sickle cell patients to try to understand what happened and what went well and what didn't go well, and sort of what some of the factors were. But the one on the top from HUP was approved as QI because in the language they described, this is done as a quality improvement initiative to improve the way we deliver care. While the second one at Penn was described more as, we want to learn about sort of generalizable knowledge. So if we get this data, we can help other health systems across the country learn. And so even the same project might have different intent. So I think that was an important learning. And so as a result of that, this is sort of like the pathway that exists today. And the first key step in the pathway is that we ask the teams to go to some operational leader, division chief, department chair. We try to make it a very easy process that relies on them to do that. So we don't ask these leaders to kind of like fill out forms or things like that. We just say, if you name this individual and you say that you've talked to them, then that kind of helps to define the sort of the quality sort of operational aspect of it. And in that pathway, there's 3 different ways to go about that, 3 different responses that you might get. So, or 3 different ways to go through. So the first one is if they review it and they think it's research, it's externally funded, it's the primary goal is to create systematic knowledge, it's something that they think might be high risk. They just tell you to go through the standard IRB process, just as you would otherwise. In the middle pathway is when you're not really sure and you can submit it there. And so in that pathway, they review it. It could go to research, or they could just send you a letter back, basically saying this is deemed as quality improvement. You can use that letter and submit that to journals or publications. And the last piece, which is sort of interesting also, is that if the operational leader thinks that this is straight up QI, they can also say this doesn't even need to go through this QI IRB pathway. And if you do so, you can just say this was deemed as quality improvement, so we didn't actually submit it to the IRB. And that's important also because we didn't want to sort of open up the floodgates, and the IRB folks didn't really feel the need to kind of review a lot of these. And so these are the statements that you can use to publications and to journals and for abstracts to describe kind of what the process was. So if there's no review, but you basically say it was QI and it was not formally reviewed by the IRB. If it went through the QI IRB, they say it was reviewed and determined to qualify as quality improvement. They send you back an email or a letter, and basically you can use that and submit that to journals if they're interested. And the last one is that it was actually approved by the IRB if it does indeed go through that standard HS-IRB process. And so now I'll talk just a little bit about some case studies and some edge cases, because I think that one other thing to highlight is that as the more we go through this process, the more we realize that there's not this sort of delineated way of doing it. The way Penn does it might be different than the way other institutions do it. And I have seen, actually, since we've done this about a decade ago, lots of other institutions have similar pathways. They're often arbitrated through their sort of CMO or quality office, where they also review these things and they'll decide which may or may not go to the IRB. So lots of institutions do have a similar type pathway to kind of help with this. But these are just two examples from my own experience. And so, as Jen described, it's a system-wide goal to improve colorectal cancer screening rates. It also happens to be a main area of my own research. And so the left side was a study that was funded by my K Award just a few years ago. And in this one, the idea was, how can you think about behavioral interventions that might increase response to mailed fecal immunochemical testing or stool testing for colorectal cancer screening? And so it was funded externally by the National Cancer Institute. We wanted to run it as a clinical trial. And I think some of these projects can go through the Squire. Some of these can actually be run as clinical trials. And a lot of the work I do, particularly that's externally funded, is run as a clinical trial. And I think it provides a little bit higher scientific rigor. If you know what you're trying to test ahead of time and you're not sort of changing a bunch of different things over time, or you're not including lots of different things, ideally, from a scientific standpoint, you want to predefine your hypotheses, you want to predefine your protocol, you want to post it on some type of registry or external website, and then you want to hold yourself to that methodology the same way you would if you're evaluating a new drug or vaccine or therapeutic. We want to hold ourselves to the same standards when we think about behavioral or system-wide interventions. And so the things that we wanted to test were this sort of user-friendly, kind of fancy packaging compared to the standard packaging. So that's because of some early quality improvement work at Lancaster General. We wanted to see if adding text messaging could increase uptake. We wanted to see if having a personalized mailed reminder could increase uptake. All of these things we wanted to test because they're a little bit more costly, and we wanted to know if it makes a difference or not. Otherwise, there's no reason to make investments in any of these things. And so we ran it as a clinical trial. Interestingly, I'm not going to go too much into it. The packaging actually made no difference. The texting increased response rate and the mailed reminders increased response rate. We're in the process of publishing it. We didn't even go to the QIRB. We went to the straight IRB. We did get a waiver of informed consent, and I'll talk a little bit more about that, because there's no way we could have consented these thousands of individuals that were not up to date on colon cancer screening ahead of time to be able to even send it to them. So it wouldn't be practicable. The second one was an interesting initiative so this one was originated by my research team, and we brought it to primary care. We conducted it in partnership with primary care, and it was sort of implemented by my research team. The second one was something that came about through a partnership with marketing. So Penn Medicine is one of the sponsors for the Sixers, and through a partnership with the marketing department, we wanted to figure out ways to kind of leverage that partnership to see if we can get more people screened. So they're doing all sorts of advertisements about colon cancer screening and breast cancer screening and other types of screening. And then they basically said, maybe we can think about sort of a co-branding when we send these outreach out, and even giving people a discount to buying Sixers merchandise, because we know Philadelphia residents are big sports fans. And so maybe that might be something that might work. And so there wasn't really a research intent. They're originally just going to roll it out in the next phase of outreach. And of course, being the sort of randomization person that I am, or the sort of interest in that, I always sort of throw out the concept of randomization. So I said, if we're going to do this, why not randomize them individually to see if it makes a difference or not? Because if you just offer this in April and then send something else in May, so many things are changing all the time whenever we do these things. There's actually huge variations in terms of response rates based on how we're doing it in the context of the month that we do it. And so they are going to run it as a kind of, ideally by randomizing. It's not a clinical trial. It's not even clear if we're going to go to the QIRB or not, if it's something that we're interested in publishing, but it just highlights that these are very similar projects if you think about what we actually did. But because of the intent, how we did it, external funding, the evaluation design, they're sort of going through slightly different pathways. And so just as we get to randomization, there's a couple of pieces in the New England Journal from a few years ago that talk about this concept of randomization. I think this is something that we've changed sort of the mindsets of. Historically, randomization equals research. I think that's what everyone's mindset was. What we've learned is that we can actually do lots of randomization in the health system. And frankly, the state of the art in the digital sphere, Google's doing A/B testing all the time. Everybody's doing A/B testing to figure out what works and what doesn't work. That's a much more rigorous method than pre-post evaluation or other types of study design. So Leora Horowitz and her group at NYU, they have a Center for Healthcare Delivery Science. They wrote about how they basically work with the health system to think about areas where there's equipoise and how they can add randomized evaluation. So they have a statistician or a sort of trial design type person. But interestingly, the vast majority of these are not run as clinical trials. They're just sort of quality improvement, randomized interventions. A lot of them are published, some of them are not published, and they provide, from their perspective, a lot of value to the institution to say what works and most importantly, what doesn't work. So you don't have to waste resources on things that may either not work or may have actually worse outcomes. And then David Ash, myself, and Tracy wrote a paper in New England Journal, mostly about kind of the waivers of informed consent. Historically, the idea was that it has to be low risk, it has to be aligned with operations, and it can't be practically performed. So the example is, with mailed cancer screening outreach, we can't reach out to those 5,000 people. But the other thing that we sort of added on as a layer is that as we think about behavioral interventions, when you think about the consent process and people have to opt in consent, you get a very different patient population and it makes it less generalizable. So we can't actually answer the question that we want to answer if we have these sort of mechanisms, traditional mechanisms of research. And so just trying to think about kind of more expansion of waivers of informed consent, as long as it is ethically sound and is safe for patients and things like that. The other thing we've learned is that many of these things are things that actually enhance care and are based on lots of evidence pathways. So if we think about excluding certain, what we think of as vulnerable patient populations, this actually just came up with one of my research projects. You might actually be, we want to protect them. So the things that have come up are HIV patients, substance abuse patients, who might be residents in prisons or things like that. If you exclude a lot of these patients, then they may not be benefiting from these things. And so you don't learn about whether it works or doesn't work. And if these are also improvement initiatives conducted with operations, then you're systematically excluding people from getting, breast cancer screening outreach or colon cancer screening outreach. So these are ethical questions that we're always grappling with. And so I think this is my last slide, and hopefully it'll lead to some conversations. So I'd love to hear the perspective of folks in the room or following virtually. But these are some of the things that we think about when we think about whether it should be sort of considered more traditional research, whether it's this overlap or whether it's just sort of traditional QI. Prospective randomization of interventions, I talked a little bit about that. I think we need to move away from this concept that randomization equals research. I think really good QI could have randomization and could actually be much more effective and ethical, I think, because as it is in any QI project, we're selecting places to get it and we're selecting places not to get it. If we started at HUP, we're systematically saying that HUP patients are going to get something and Presby patients aren't going to get something. External funding is a consideration, whether it's a new device or therapeutic. So if you're using some new AI algorithm or some new technology that has not been proven in the past, you might want to think that perhaps it's more along the research realm. The risk of the intervention, I think, is probably the most paramount thing. How risky is this? How much is it within our existing scope of practice? How risky is it to patients, and should they be aware of it? Should we think about that concept? Exclusion of certain patient populations. So I talked about that a little bit. And one thing that it is worth knowing is that if you want to submit something in clinicaltrials.gov, you actually have to have an IRB number. So if you want to run it as a clinical trial at this point in time, based on my experience, you actually do have to have an IRB number. So you do have to go through the traditional IRB pathway. So with that, we'd love to see if anyone has any questions or comments.
I can start. Those of you online, please feel free to raise your hands or chime in. So this was a great rapid overview of some of these tricky line drawing challenges. And so in my mind, the ethical question is less about whether something should go through the IRB versus whether something requires informed consent, right? And so the kind of initial split is traditionally, right? is this something to produce generalizable knowledge, as you were saying? And are you interacting and intervening with people to gather that generalizable knowledge? But as you showed, it can be really tricky because you can have a primary goal of influencing local practice, but you also want other people to learn from what your institution did. So that's a fuzzy dividing line. And when we think about why do we have IRBs, right? Like what are we expecting them to look out for? At root, they're supposed to be protecting patients against the inherent conflicts of interest of the researcher, right? Because the researchers are not making the same kind of clinical judgments that they would make in a one-on-one doctor-patient relationship, right? You're following a protocol. So those are some of the reasons why we have IRB oversight that also could come up, right? In the context of a QI project, you're following a protocol, you're not making individual level decisions. So I struggle with the question of like, does it go through the IRB? Does it not go through the IRB? Should it be expedited? Should it be exempt? You know, all of those things, because it is in many cases low risk, right? Compared to what you could do without going to the IRB. Like the CEO of the health system could just say, we're doing this now, right? Everyone's going to do it. We're not going to learn. We're not going to randomize. We're not going to ask anybody for consent. And so it does create these weird incentives to say, oh, well, now you want to gather data. Now it's research. And that's going to be a pain because you're going to have to go through this whole process. And so people say, oh, it's easier. I'm just not going to gather the data. Okay. All of which is to say, I struggle in my own mind of trying to figure out whether these projects should go through the IRB or not. What I think is much clearer is that we have to come up with a better approach to the consent question. Because as you were saying, the question often falls to, is it practicable to do the research if you have to get informed consent? And people don't have a clear sense of what it means to be practical, you know, how much can you influence the outcome before you say, no, you don't have to get informed consent. So that was a long-winded non-question, more of a comment, but I would love your thoughts about where it makes the most sense to pay attention. Is it this bifurcation between IRB or not? Or is really the ethical challenge more about consent or not? Or maybe you think they're both kind of equally ethically relevant.
Yeah, I mean, I can start.
You can start. Sorry, that was a lot.
The IRB is sort of it's a construct. So I think we talk about the QIRB. The purpose is not. It's not an ethical nature purpose. It's a more practical nature of, you know, how do you get through these pathways? How do you make sure the right people look at it? How do you make sure the right people make the right decisions? And you know whether it should go to the IRB or not. That doesn't answer the questions about risk and, you know, patient autonomy and all those different factors. I think I agree that that's the more important question. Because, you know, also a lot of my research studies, we get waivers of informed consent. That's where it gets more ethically challenged. You know, if I'm mailing out fit kits to people, I can't even reach out to them. And I'm just offering different things that many people would offer, and we need to know if it works or not. I feel very comfortable in that aspect of it. When it gets to things that are more interventional, so I can give you an example. I have two hypertension remote monitoring studies that we've done. One is called Support PP1 and one is called Support PP2. The Support PP1, we had a informed consent to be involved in the process, and basically only about 30% of people consent to get remote monitoring, even though remote monitoring is done across the country. We want to know if it works or doesn't work. And as a result of that, the people in the control group actually got 40% of them had controlled blood pressure by the end of it, because we're selecting a very highly selected patient population. And so therefore we're not able to actually test what you know, if I were to offer remote monitoring of blood pressure in a routine practice, which many people do today, I would just mail people the blood pressure cuff and start just offering it to them, just like we would for anything else. And, you know, by people choosing to participate, they're basically implicitly consenting. Like if you didn't want to participate, you don't have to necessarily. And so we do that, and the idea is that we would see if that works or not. But with the opt-in design with consent, we're not able to actually figure that out. In a secondary study, we actually found by not having an extra research touchpoint, we just used existing data. We found that the exact same program or very similar program actually did make a difference in blood pressure. And so we're literally changing our finding based on who we include and who we don't include as much with this. And so that's where I think it does get a little bit thorny. Now, the other things that have come up aren't just whether you get consent at the beginning or not. how do you inform people afterwards? Can you tell them after the fact that, you were involved in this outreach study or things like that? Those are areas that I'd be very open to thinking about to make sure that people are aware. So then later on, they're not seeing some jam article or something saying like, oh, I was part of this experiment. I didn't know about it. So we've worked with the IRB to think about, are there other ways to disseminate information to communities or to patients to say that we're testing these types of things, or to say that when you come to a place like Penn, we're always testing out different things. And so they don't feel like they're blindsided by that. And they don't feel like there's that lack of trust, particularly when we have diverse patient populations that we do at Penn.
I think one of the other thing that your question brought up, Holly, and I agree that the informed consent piece is more important than the IRB itself, is that the subjects, the participants, right, are sometimes not patients. Sometimes they're the providers or the nurses. So often in QI, we're asking staff or providers to do something different. And so that's another element that we often think about. There's a question back.
Yeah, thanks. Just following on from Holly's question. I'm curious if you can say a little more about cases where you felt there were concerns about risk to patients and investigators thought, no, this is all QI and we don't need to do anything about it. There's that interesting split, right? On the one hand, as I think both your presentation showed and Holly also just said, we're like, we're just doing QI here, but we want to do really rigorous research because we're Penn. And the split can then often be that people are saying, no, but this research is so important. We really, we just have to do this. Yeah, we have to do it fast. So I'm just curious how in your world that plays out, how those conversations went when you thought actually there's more at stake here for patients. How do people in the field then think about it in terms of saying, no, we're good? I'm just, a little, I guess, nervous about how you instituted that level of self-policing through department chairs and division chiefs and people like that who all are, as Holly said, right, have different other interests that can be competing.
Right.
And much as I see the beauty in terms of efficiency, there's also, it goes directly in the direction of the reason we have the IRB in the first place is that we want to protect patients from other interests.
Yeah, can you go back to the slide that has the split, the pathway, Shivan? So I would say, whenever we have someone that is not sure, or let's say they really want to ensure that someone else's eyes look on this, they might be biased or for whatever reason, we always encourage them to do the short application and let the experts from the IRB look at it, ask those questions and get their perspectives. I would say more often than not, it's not that the IRB, it's less common for a group to think it's research. Like once you start going down the research pathway, and Shivan, you can tell me what your experience has been, but once you start going on the research pathway, no one stops to say, hey, this seems like quality improvement. That's unlikely. Like the language that is expected, the questions that are asked, more commonly, you're in this blurry space, people aren't sure. And so we as leaders and advisors and other leaders in this field will say, you know what, do the quick determination. That way you have that unbiased person that has expertise in research and institutional review to let them make the decision and ask those harder questions.
Yeah, and I agree. Jen and I would never be involved in a project that involves that, but we have secondhand knowledge. No.
Yeah.
So you're right. So I think we always encourage people to go here, and to be honest, like the IRB is doing a service to us as researchers to help us to kind of figure it out. We need that objective guidance, and we appreciate that. And some of it means submitting it. Some of it means actually just reaching out to leaders at the IRB too. They've been very, very great to collaborate with. So that's always been a very useful conversation. Because like sometimes when you submit a 2-page document, it doesn't get to the full nuance of it. So that's another alternative pathway. And they've always been very open, just reach out to somebody from the IRB and ask them and have a conversation about it. But you're right, there are lots, there might be, new surgical techniques, new anesthesia techniques. AI is another great example of something where things are happening all the time. Surgeons are trying new techniques, and perhaps it might be at the leading edge, or it might be risky. And we may never know about it because we're not involved. But that's why I think socializing this as much as possible may not only help people move from here to here, but also people move from here where they're just doing it anyway to here. and to help identify that. And that's a sort of safety, ethical issue. And so from our perspective, as many people submitting as possible is always a good thing. And I know the institution has put a lot of guardrails on, like AI is a great example of that, where I think to do a lot of these projects, you have to have certain specific types of approvals to move forward, because I think there are concerns about, we're going to offer somebody this drug or this medicine or this therapy just based on some AI algorithm that hasn't necessarily been validated. I know there's examples of, I think there was an example of sort of a xenotransplantation at some other institution that I read about, where they sort of transplanted like pig heart to somebody, and it didn't go through, it wasn't even a research study. I don't know if, it may have gone through an ethical pathway, but our hope is that these do move into a research pathway. I think there's a lot of benefit of that with a systematic evaluation and sharing with other people about what works and doesn't work. But that's up to those institutions and those individuals to decide if they want to do that or not. We do it because we believe in it, and we're an institution that celebrates that incentivizes that with promotion and things like that, but other institutions may not.
Go here first and then Katie, we have enough for two. Enough time for two.
Yeah.
Okay, thanks. I was wondering if some of these projects might have room for something that traditional research wouldn't, which is that either patient subjects or the staff who are part, like, get to choose which thing they try based on their own values. So say you're someone who I like to take risks and be on the forefront. So I'm gonna take the whatever that was for the surgery the night before. Because, I got to choose between do the standard thing or here's the explanation for why we're doing this trial, and you get to pick which one. That's obviously something you don't really ever do with traditional research, but if it's still better than not researching it at all, and you get to kind of give back some autonomy and incorporation of people's values. I don't know if you have any projects that do anything like that.
Yeah, I don't have any personal projects, but I've seen in the literature, there's a lot of the things we do, we can't force clinicians to do, we guide it, we provide nudges, that doesn't mean they actually do it. And at the end of the day, they're going to do whatever they do. So there's a lot of, I know, medical, clinical studies, for chemotherapies where there's a lot of crossover and I know I've seen it with colon cancer screening, you get assigned to the colonoscopy arm, but because your clinician doesn't want to do that, they move you over to the fit arm, or they offer you different things. So that's happening always. But I like the concept of sort of giving people, that the intervention is not, guiding them towards a particular therapy. The intervention could be allowing them to choose what they want. So I think that's a really interesting concept for research.
Yeah, I mean, it's something, if you remember that, the spectrum, it's something that we do every day on individual clinical innovation, with individual patients. Okay, what option, would you like to do? Would you like to find out what this mass is and get a biopsy, or would you like to opt for palliative care? So it is an interesting point.
Yeah.
So I was wondering what your sense is of the extent to which sort of I guess you'd call it the rank and file, the frontline staff are aware of these varying processes for looking at projects, and then also what kind of guidelines are out there so that when people do QI, they do it with some rigor and appropriate methodologies?
Well, I'd love to take that one.
Yeah.
So I would say rank and file, meaning frontline nurses, physicians that are not involved in quality improvement or research. I'm sure they have no idea.
Or the ones that aren't
That this
research-oriented.
exists, correct.
Yeah.
When the radar goes up is when you start thinking about disseminating the work to an external body. I want to create an abstract, a poster, a manuscript, and then you generally need someone on your team that has written before and has interfaced with the IRB. And so I think teaching faculty, program directors, nurses that are involved in training programs or research programs, I feel that they do know about this. It's been around for 10 years. You can easily find, if you Google QI IRB in Penn, as Shivan said, many other academic medical centers have something similar. So does that answer the first part of your question? The second part of your question is, how do you ensure people do rigorous QI? That, it depends on where are you? Who are the educators and advisors? How much emphasis and resources has the healthcare system put into their Department of Quality Improvement? Do they follow a standard methodology? Is there an office where you could go to for guidance?
Is there?
Yes, so, I'm just glad that our CMO is in here. So you go back to that blueprint for quality on one of my first slides. So the Office of Clinical Effectiveness and Quality Improvement, it's an office that's health system wide. We have a chief quality and safety officer, and all of the hospitals and main entities have a quality office with a director and associate directors. So they're sort of the keepers of the knowledge. Again, so that I think is what determines it more than anything else. You know, so much of quality is wrapped up in operations and leadership of departments and healthcare systems. Like, and even a decade ago, there weren't chief quality officers, vice chairs for quality. Like, this is all very, very much driven by those drivers that I mentioned. And I think we're all getting better and doing it more rigorously. And I think that's a lot of what our centers are about. We had a couple of slides at the very end. We just wanted to share, since we're new to you and you're new to us. So I lead Penn CHIPS, which is the Center for Healthcare Improvement and Patient Safety. So we have a certificate, a master's program, and a research concentration, and a community of people. And so we're constantly having people refer to us that are starting their journey or just want to take one particular course. So again, that speaks to the institution and its investment in being at the forefront of this field. And then
Yeah, and I've been at the Center for Healthcare, now it's called the Transformation Innovation Center, for a decade now, and we lead lots of innovation programs across the health system. Also do a lot of learning health system work, in that we have embedded cores that have both a research and a clinical operations function. We have a Center for Health Justice, Pop Health Lab that my group runs, and Nudge Unit is part of that as well.
Thank you very much.
thanks.